Good evening, everyone. Thank you for joining us. Welcome to what should be a really great discussion on the pandemic and its impact on women's health. My name is Carly Weeks. I am a health reporter with the Globe and Mail. I've been covering COVID-19 since the beginning of the pandemic, with a nice big long break in there where I had a baby and went on maternity leave and got a nice time away from society. And so I, like everyone who's going to be talking tonight, and probably a lot of people who are watching, have personal experience with, the health effects of the pandemic. And we're really lucky that we've assembled this really great panel to talk to us about what we know so far. What are some of the emerging concerning trends? What's sort of big questions do we face? And how do we reckon with, the biggest health crisis in generations, and how we begin to start to address some of those issues. So I will, without further ado, I'd like to introduce the esteemed panel that we're really lucky to have with us. First up, I will introduce Ashley Twitt. She is an assistant professor at the Dalla Lana School of Public Health at the University of Toronto. She focuses on the use of epidemiological tools to improve decision-making for the control of communicable diseases. We also have with us Nisha Thampi, who is an associate professor and pediatric infectious diseases consultant at the University of Ottawa. She is, Dr. Thampi is a pediatric infectious diseases physician at CHEO in Ottawa. She's also assistant professor of pediatrics at the University of Ottawa, and she focuses a lot of her research on surveillance and prevention of pediatric infections and public health promotional strategies among children. Next, we have Tara Moriarty. Tara is an associate professor at the University of Toronto Faculty of Dentistry and Medicine. She's also an infectious diseases researcher, a co-founder and co-lead of the COVID-19 Resources Canada, and advisor/leader with CanCOVID, Science Up First, the Canadian Lyme Disease Research Network, and the Network for Canadian Oral Health Research. And rounding out our panel tonight, we have with us Iris Lesser, an assistant professor at University of the Fraser Valley. She is an assistant professor in the School of Kinesiology, a certified exercise physiologist, and a pre- and postnatal specialist with the Canadian Society of Exercise Physiology. And she's interested in using exercise as therapy for mental health in at-risk populations. So as you can see, a really well-rounded panel. We're going to be getting to a ton of different issues, and also, of course, some of the audience questions as well. So if you do have a question for the panel, something that you'd like to say, please send it in. We're going to try and get to it throughout the panel, or perhaps we'll see how things go. We'll get to them at the end, depending on how many we have. And we'll make sure that everyone gets out of here at 7 Eastern, but we have, I'm not going to keep talking. I'm going to let all of these experts take over, and I'm going to try and grill them as best I can on some of these issues. I wanted to start first with Iris. As someone who does a lot of research focusing on pre- and postnatal women, you have a baby at home yourself. And I wanted to know, right now, you're doing some research looking at the impact of COVID and how women might be using exercise to help improve their physical and mental health. I thought it would be a good opportunity to ask you about what sort of things you're seeing and hearing from, from women who've recently had children, some of the experiences that they're going through, what your research is telling you, and what some of the, issues or concerns that you have based on what you're seeing.
Thanks, Carly, and thanks for the opportunity to speak tonight. I have been doing some work looking at specifically postnatal women. So women who have had a baby in the past year and are in Canada likely on maternity leave, having time to spend with their child, but also at a very unique time. So maternity leave and that 1 year postnatal was something I was already really interested in from my own experience with my first daughter and then having another one in the pandemic. It's a trying time to begin with, both physically and mentally for women. And we always hear about all of the supports that we should rely on so that we can make sure that we have a positive physical and mental recovery to that experience. But come along COVID, and suddenly essentially everything we've told women to do has been pulled from under their feet. And so I know Carly and I both had our second child, so we were a little bit luckier in the sense that we sort of knew what to expect. But to now be in this experience with COVID where we don't have access to the same prenatal support. So doctor's appointments are online, ultrasounds often without support people, not having visitors when you give birth. All of these factors are, of course, a very different experience to begin with. And then you bring your baby home and you're already worried about infection with a new baby. And now you've got COVID everywhere. And so you've got isolation and a lack of support. And so we were planning on doing something around physical activity before COVID had ever started, because mental health was already an issue. And we were already seeing anxiety and depression going up in the postnatal population. But with COVID coming along, we were like, well, there's never been a better time to try to find a way to support these women. And in my field, physical activity is sort of the therapy we turn to for everything. So if we know that women are struggling with their physical and mental health, we know that exercise is really good for that. We know there's a really hard challenge in terms of becoming physically active after having a child and how to support it. And so what we ended up doing was creating an outdoor exercise program where moms could come with their babies. We had a group fitness instructor and we did interviews with the women before and after they did the program. We're also going to follow up with them at the 6-month mark. And we checked in on things like anxiety, depression, exercise self-efficacy. So how all of these things might be improved or altered after engaging in this type of outdoor socially supportive physical activity program. And so that's what we've been working on. We're seeing positive findings coming out of it. So we're seeing improvements in depression. We're seeing big changes in motivation, specifically intrinsic motivation. So that desire to go out and be physically active has improved quite a bit. And so exciting things and things that I think we potentially really need to realize that this should be part of postnatal healthcare, that we need to provide this type of opportunity for new moms.
That's a really interesting point. And, I think one of the things that COVID has taught us is that in many ways we have been, or it's shown us some of the areas where maybe we've been neglecting things for far too long. We've seen this time and again, looking at issues around long-term care. And that's something that we're going to be talking about in just a little bit. But it's really interesting that your work is informing that, so that hopefully this can lead to those kinds of changes so that it can benefit women for the long run, not just those who might be isolated because of COVID, but now we know this is an issue that a lot of people face after having a baby, right?
Yeah, absolutely. So, COVID's, of course, got many negative aspects, but it has forced us to sort of reprioritize our thinking. And I think that's one of the areas where we could put a lot more energy into.
Mm-hmm. Yeah, and I think that, as someone who's covered health for a really long time, I can attest to the fact that we know women's health has often, it's often forgotten or overlooked, or it sort of is taken for granted that maybe it's just the same as men's. We've heard of that classic example of, women being excluded from cardiovascular disease studies, because we're just assumed to have the same physiological outcomes as men, when we know, in fact, it's much different. And of course, people like yourself, there's a lot of research going on to try and really unpack exactly the specific issues that may be affecting women. But it's really, I think, great and heartening to see this work being done that can, help lead to some important changes. So we'll talk some more about some of the things that you're working on and finding. But I thought, if we're kind of going through the life cycle, if you will, so we have women who are having babies, and then we also know that COVID has obviously impacted everybody, not just women, like literally everybody. So I wanted to get Ashley and Nisha to perhaps both weigh in here. And this is talking a little bit more just generally about, young women, girls, the impact that COVID has had on them. And I know that you guys have been doing some work kind of looking in this area, maybe not, specifically looking only at girls per se, but I wanted to just ask you sort of in an open-ended way, what some of the things you are both finding, and maybe Ashley, I'll ask you first, some of the things that we know already that COVID has done to women's health, some of the areas that we need to prioritize or look at, and then Nisha, after Ashley is done, I'd love to ask you the same thing. So Ashley, please, whatever your take is on that, it'd be great to get your perspective.
Okay, thanks. I can probably speak less to the adolescent health than Nisha, but I'll speak sort of more generally, and then we can hear Nisha's
That's just fine.
More intelligent insight specifically with respect to adolescents and pediatric health. But I mean, it's a huge question, and it's a really difficult one to answer. You know, when we think about the impact of the pandemic on health writ large, you know, you can think about the impact of COVID itself. And then, you know, we can talk about the indirect effects of the pandemic. And I think, you know, we've talked so much about the direct effect of the pandemic that maybe I'll talk a little bit more about the indirect effects. But, you know, there's been a huge disruption to our healthcare system. And I think at this point, you know, we're still figuring out what part of that disruption has been good and what part of it has been bad. You know, the shift to virtual care, you know, for some segments of the population has been a good thing. And for others, you know, they've been left behind, you know, people who don't have access to stable internet, for instance, or who are comfortable or don't have circumstances at home where they can, you know, talk about personal health matters on the phone. So, you know, I think that aspect of it has, you know, really sort of, on the one hand, moved virtual care forward. And I think in a way that wouldn't have happened had the pandemic not occurred. But I think we still need to figure out exactly, you know, who's been left behind. And, you know, sort of tying back to what Iris was talking about, you know, when it comes to sexual health, I think that's one area that is really interesting. And it's an area that, again, you know, we're still, you know, early days understanding exactly what the impact of the pandemic has been on, you know, first of all, like access to sexual and reproductive health services. You know, early on in the pandemic, there were shifts in terms of how prescriptions were handed out. So the recommendation was that people only got their prescriptions for 30 days because we were worried about shortages of drugs. And so with respect to contraception, you know, that was a situation where for people who have, you know, aren't able to get to the pharmacy every month, you know, may have had difficulty accessing contraception. We know that there have been disruptions in terms of screening for sexually transmitted infections. And for instance, syphilis right now in sort of Western Canada is a big deal. And I know that there was some conversation a few months ago in Alberta where their chief medical officer of health sort of raised the specter of syphilis as, you know, this example of why we need to not just think about COVID. And she was kind of mocked. And, you know, that's, you know, COVID is a big issue, but at the same time, the fact that we're seeing congenital syphilis, so we're seeing babies born with syphilis, which, you know, in public health, you sort of learn in sort of epidemiology 101. If you see a child with congenital syphilis, that's a massive system failure. That shouldn't be happening, you know, in the current period of time where we have, you know, women should have access to prenatal care and where we have an easy and accessible treatment for that. And so I think, you know, in terms of, you know, it's messy. I don't have a coherent or sort of simple answer in terms of, you know, what this means and what we're learning, except for the fact that I don't think if, you know, 2 years ago you had said to us all, you know, we're going to have this novel pathogen introduced into our population, predict all of the ways that it's going to disrupt our health and our wellness. I don't think we would have really been able to capture sort of the ripple effects of this. And it's something that, you know, over the coming years and decades, we're going to be, you know, continuing to learn and understand more and more about, you know, exactly what this particular sort of, you know, the pandemic and the pandemic response has done and how it's affected women's health. And, you know, not, you know, when we talk about women's health, it's not just, you know, women, again, you know, as one large group. There are these huge differences in terms of how particular sort of marginalized populations have experienced this, healthcare workers have experienced this. So yeah, that I'll leave it here and hand it over to Nisha.
And just Nisha, before you do begin, you know, and that was a fantastic way of putting it, because yeah, no one has any clear answers. I think that we're all kind of muddling through this, right? But one of the things I thought, Nisha, maybe you can touch on this as well, but we've also heard a lot about how much missed screening there is right now for or missed vaccinations. So, you know, we've heard a lot of anecdotal reports and some fears about, you know, so many different populations missing routine vaccinations in childhood, including the HPV vaccine. So I don't know if that's something you can touch on as well, just about how some of the long-term impacts we might be seeing.
Yeah. So, I mean, talking about children in the context of this is tough, but I think Ashley framed it really well in that we've had a shift to a different mode of managing children's life transitions and healthcare services, and it's worked well for some segments of society. And we're learning, and we continue to learn about who's being left behind and how we have to address their needs, either urgently or just as much as other children. In terms of, to get to your point about the missed vaccines, that has been a concern along the continuum of childhood. So whether it's parents who are concerned about going to the doctor's office or the doctor's office not being open and available to provide routine immunizations at a frequency or a timing that works for families. It's, so I've been fortunate that my family doctor has been fairly accessible, but I know that others have not been, and that's been exacerbated by the pandemic and the screening and the symptom-based screening programs to be able to get into offices. But and public health units have been trying to address that, but again, it's about working with what's convenient for families and easy for families to access, which has all been disrupted and not really course corrected yet. We're getting there, but it requires an additional resource, an additional ask for providers and for families. But I think more broadly, there has been a disruption in access to healthcare services, recognizing that pediatric healthcare services are very specialized in terms of where the care can be provided, who provides that care. These are not like the healthcare workforce in pediatrics is like of another level of specialization than the adult healthcare workforce, and they're not interchangeable. And so there's generally less bandwidth to absorb additional cases of critical illness. And so, the pandemic has shown us that, we can take these disruptions, seasonally, and even then it's very frustrating for some families that have had care disrupted because we're in a seasonal surge. But when we're surging now for, a year and a half to 2 years, we're starting to see, and we're acutely aware of who's being left behind, and it's incredibly distressing. And it's hard to parse out that data by gender, because really all children have been affected uniformly in this process. There's also been disruption in education. So we're coming up to our we're in the thick of our third academic year that's been disrupted due to the pandemic. And, there are international reports that have flagged a concern that 11 million girls may not return to school. That was after the first year into the pandemic, specifically girls aged 12 to 17, and that was more in lower income countries. But we just don't know what this is going to look like. These disruptions are going to look like in Canada and in our provinces with the stop-start. Cohorting of classes, the various changes that have been made in the curriculum, as well as in the way kids go to school. So there's some emerging evidence about the impact of these disrupted life transitions, like going academically year to year, or transitioning from high school to high school, or from high school to universities, and I think it's important to recognize that we're still learning about this, but we don't know yet what the impact will be for women in particular, but across the spectrum. We'll really only learn that in the next few years as their potential is realized. in school and in university. And when I talk about disruption in education, I'm not just talking about the learning in a classroom setting. I'm talking about education around sports, around music, and around socialization, because adults may not appreciate it, but children are learning how to socialize in the first 18 years of their lives. They get some of it from their parents, but in-person learning is so important for their social development and how they negotiate difficult situations and partnerships, and that has all been disrupted.
Yeah, it's you know, I think everyone would agree. You know, what's gone on with kids in the pandemic has been a tragedy. You know, we keep hearing the same refrain again. Well, kids are resilient and all of those things, but you know, 18 months, 19 months, 2 years in. You know, no one is that resilient, right? And so it is concerning to think about some of the things we're going to see unfold, you know, in the years to come. And we know there's a lot of short-term health impacts that we're seeing unfold right now. And would like to talk about some of those in a couple of minutes, but a lot of the longer-term ones as well. I thought it would be worth asking Tara now to chime in and provide a perspective on what happens at the end of life. And I know that this is not something that you study in reference particularly to women, but you have been looking very closely at mortality data in COVID-19. And I thought you could share some of the perspectives that you've gained, some of the things that you've seen just in terms of you know, who is dying during this pandemic, and any specific insights you do have as it relates to women. I mean, we know this pandemic has been really unforgiving to a lot of seniors in long-term care, and there are a lot of you know, women in long-term care. But please, yeah, share with us some of the insights that you've gleaned doing some of the important work that you've been working on.
Oh, thank you. So, I mean, I think that I should maybe explain a little bit how I ended up coming to work on long-term care deaths. And part of it was highly personal because both my parents had and have dementia. I'm a primary caregiver. My dad has passed away. We were living with my mom. And you know, I knew how difficult the home care and a lot of these systems were. So, and I know how challenging, how not all that well a lot of these systems work under the best of conditions. So when COVID happened, you know, we sort of witnessed the collapse of all of my mom's dementia day programs, the loss of home care workers who were completely unprepared for what was coming. So I was trying to get them gloves and masks and make sure that they knew what to do. So I think that a fear about that, a fear that things might fall apart and probably were falling apart, was what started me going on this. And then watching really closely what was happening in long-term care and the deaths in long-term care. But ultimately I ended up studying other types of deaths that were occurring outside of long-term care, because most other countries have had a significant number of seniors and older people die in community, not just in long-term care. And we probably have had those deaths here in Canada. They just weren't maybe noticed or as obvious. But along the way, and we started doing a lot of vaccine outreach support for seniors really early in January, because you know, there weren't plans in place to help people make decisions about vaccination. There was no support in place. People were very frightened actually in January. So we started providing a lot of volunteer scientists and pharmacists and physicians who were answering questions from seniors, from caregivers and others about COVID-19. And one of the people I met doing that is Janet Mcelhaney, who actually died quite recently. Janet was an end-stage cancer, a really wonderful geriatrician and geriatric immunologist. And she was joining these sessions to help answer questions. And she talked a lot about the impact of the epidemic on older people's physical health and social deterioration and mental deterioration because of the isolation. So a lot of people were very afraid to leave their homes. That was accompanied by a lot of physical deconditioning, which Iris could tell you is, especially as people get older, it's really crucial to stay physically active, because once you lose it at a certain age, it's hard to gain it back. People were very emotionally isolated. And she talked a lot about that and about this enormous impact on older people, especially those who might not have had family or who might not have spoken English, for example, or been able to use internet, because so much of our communications being internet based, and the effect that that's had on the quality of life and possibly the lifespan of older people who needed all of these sort of protections in place to be able to maintain a vital life that matters to them, and which is also essential for promoting quality of life and longevity. So women, in all of this, women have very much been affected. Women are primary caregivers for most elders. The collapse of home care and a lot of these services has been absolutely excruciating for most families. When things were really bad during the first wave, we had become unable to take care of my mom shortly before. We took her out of her home. She was in a dementia unit, and took care of her by ourselves during the first wave, which was absolutely really, really, really hard on her, because she had no more friends to go out and visit. She was just stuck at home with me and Zoom, which, is not a life for anyone. And there are a lot of stories, people that my mom is living with now, for example, families that absolutely couldn't cope and ended up having to put family members in homes because they needed 24/7 care, and people didn't have the ability to do it anymore. And the emotional pain and challenge for a lot of families, especially women who often carry a lot of that burden, has been very difficult. And then, of course, a lot of seniors are also women too, often widowed or living on their own, much more likely to be isolated. And we don't know yet if there have been gender-specific effects on physical health for women or people who identify as women, but it's been a really, really difficult situation for a lot of older women in the country, and older people in general, but especially a lot of older women.
Mm-hmm. Yeah, it's been really heartbreaking to hear some of the accounts coming out from some of the inquiries that have been done already, and some of the reports into what's going on in long-term care specifically. But yeah, I think that we've really only scratched the surface, right? And on that vein, I guess, of long-term care, one of the things that we need to talk about that we probably haven't talked enough about in this pandemic is the impact on healthcare workers. I'll open this to anyone who wants to jump in first, because this is, I think, a really important question about a lot of the healthcare workers, specifically those who are working in long-term care. We know that there are a lot of women, for instance, working jobs that typically are low paying, a lot of racialized women, and a lot of them have borne the brunt of a lot of this pandemic in so many ways. Not only are they working in a very difficult situation, they're also part of the group that make up a lot of COVID cases, so they're kind of getting it at work, getting it home. So I don't know, Tara, if you wanted to start us off there, and then we can see who else wants to jump in.
Yeah, I mean, if you look at the data about healthcare workers that have died of COVID-19 in Canada, in the US, in the UK, it's almost always racialized people, and it's almost always people who are working in roles such as PSWs, maybe RPNs, which would be practical nurses, people who may not have access to the protections as well. I mean, I don't know how many of you remember the early stories from the first wave of people not being able to get basic masks in long-term care and not in PPE. It was pretty horrific. But we know that, for example, among healthcare workers, that doctors and nurses are far less likely to be to die of COVID-19 and be exposed to COVID-19 or the virus that causes COVID-19 than, you know, personal care aides and others who have close physical contact, but also are more likely to live in neighborhoods where they're higher risk of exposure, are more likely to be poorly paid. And in many cases in Canada, a lot of people working in these positions are actually employed by agencies, not just by the homes themselves. And they have very work that is very, I've forgotten what the word, basically they can lose their jobs easily. They don't have any workplace protections. They don't know how many hours they're going to get. And they're very vulnerable to workplace disruptions as well as really poor pay. And so this is a sector in every way that has experienced the worst of the epidemic. And we saw that a lot in January when we were initially really trying to reach people working in long-term care for vaccine outreach. And people were, I think understandably, women were understandably angry and distressed and said, you know, you can't come to help us. You didn't come into the long-term cares and stop the death and everything else that was happening. And now you're here because you wanted to get vaccinated, but you didn't show up when we really, really needed help and the people that we love and care for needed help. And, you know, it's true, right? They have a reason to be angry. So yeah, no, it's a sector that we're not seeing any meaningful changes in that sector in terms of how well people are paid, job stability. A lot of those underlying issues are still the same. And I'm not sure if COVID wasn't going to fix that situation or draw attention to it. I'm not sure when it will be fixed. But yeah, a lot of women in this situation have been absolutely traumatized and taken for granted and have had to show up day after day and go through this. And it's brutal that we've required that.
Mm-hmm. Does anyone else want to jump in with their perspective? I know, Iris, you can I think talk a little bit about this in terms of physical activity and the impact of inactivity on COVID infection. I'm not sure if you wanted to address that as part of this discussion about racialized healthcare workers or more in general for women.
Well, we did publish a paper last May that looked specifically at women's health and physical activity behavior. And I think where it links to this discussion is that the women that are in these jobs that are lower paying often have childcare issues. These are, of course, the women who aren't going to have time for their own physical health. And we do, of course, see that physical activity levels are lower in these populations because they have multiple demands upon them in terms of all of their other requirements in life and socioeconomic status. And with COVID, we did see even greater reductions in physical activity in that first wave. And what we saw were different challenges than men faced. So women were more likely to experience the challenges associated with childcare burden, with lacking in motivation, probably because of the additional requirements upon them. And the reason I draw so much attention to the physical activity piece, you might be thinking, well, we're in a pandemic, who cares if you don't exercise for a while? Well, as Tara brought up, I mean, physical deconditioning has a huge role in how people live their lives, their quality of life. And what we found in another study that we published in the fall was that individuals who had higher levels of cardiorespiratory fitness had lower likelihood of hospitalization during the pandemic. So all of these things do link together. You take these marginalized groups, they're underpaid, they're overworked, they have additional mental, physical stresses upon them, less likely to engage in physical activity. And if your physical fitness is lower, you've now increased your likelihood of infection, in addition to the fact that infection's higher in your workplace. So hopefully that drawed a couple of branches that made sense there, but certainly something that I think is worth keeping a pulse on is that, you know, physical activity does matter, and it all plays into that health and wellness and quality of life piece that, of course, went very much downhill in the pandemic.
Yeah, definitely. Ashley, you, I think, can speak a little bit just about some of the data gaps, things that we don't quite yet know. There's so many of them, but I would love to get your perspective on what you're seeing already in terms of, things that that we don't know about the impacts on healthcare workers.
Sure. Yeah. I mean, one of the things that's interesting, and I think, again, this is not unique to healthcare workers, but it's sort of how we've dealt with data in general in Canada, which is that, we don't have excellent data saying, female healthcare workers who are in this particular, line of work have, 3 times the risk of infection compared to, someone else in, physicians or whatnot. What we end up mostly doing is triangulating. So like, what are the things that we do know? We know how many healthcare worker infections, or we have an estimate of how many healthcare worker infections or deaths there have been. And we know that the majority of nurses and personal support workers are women. And we know that the majority of those people are also racialized or new Canadians. And so, you can sort of do the math and figure out, exactly who it is that's being infected, but we haven't really gone out and collected that data, which I think is, a huge gap. And it's something that, as we think about, what are the lessons that we learn from the first stage of the pandemic, I think, accounting for, the tremendous, not only physical, but also psychological burdens that have been faced by healthcare workers, and particularly marginalized, racialized healthcare workers. We need that information, and we shouldn't be reliant on sort of anecdote and, people like Tara going out and sort of doing this sort of detective work. Like, I mean, we on the one hand, you can say, well, it doesn't matter. We sort of know where the problem lies. But I think until you have those numbers and you can say, there's a 3-fold higher risk in personal support workers relative to physicians, like that number is valuable, because then you have something to sort of build off it and say, what do we need to do different? What sort of supports do we need to provide to make sure that doesn't happen again? So I just wanted to flag that as something that I think, we've been better about collecting data during this pandemic and being more transparent about it than we have been, historically. But I think there are still huge gaps, and we really need to ensure that we're, not only, talking about sort of quantitative data, but also qualitative data, and make sure that we're talking to the people who have lived through this experience.
Yeah, that's a really important point. And that's one of the things that we lament often, in trying to report a lot of these health stories, is there's simply so much that we don't know. So it is a big frustration. So hopefully, again, one of those things that COVID has highlighted, maybe we can change. Nisha, I'd like to ask you to jump in as well and give your thoughts on this.
Yeah, I think one of the most important reasons why we need these data at the granular level is because we need to ensure that there is a multi-sectoral response. So what we find affecting healthcare workers may translate into changes that we need to see in other sectors. And to Ashley's point, there have been countries that have found that have done this deep dive back in the first wave. So when we were still learning about COVID-19 and getting people tested for it, and in one of the European countries during the first wave, they were able to show that women were more vulnerable to infection based on their occupational exposure, and that what that meant was that they found that the women who had women, so healthcare workers and personal support workers were found to have greater mobility outside of the home related to their work, spent more time in the residence, had family responsibilities for which they had to go around the city to, get groceries or get kids to activities, and that they also used public transportation. They predominantly used public transportation during the early period of the pandemic. And so, just looking at women's vulnerability to infection is important. And then also trying to understand women's vulnerability to disease. So why do we see, a disproportionate proportion, why do we see a higher proportion of women becoming more critically ill with COVID-19 relative to their risk of infection? And, why are they more likely to report COVID, long COVID or post-acute sequelae of COVID?
Yeah, thank you so much for that. And, again, really important points that, frankly, it's got very concerning. And hopefully we can start to get to the bottom of that as we are hopefully getting out of the worst phase of the pandemic. Tara, I'd like to get you to jump in as well and share your perspective on this.
Yes, I actually just wanted to come back and revisit what Ashley was talking about in terms of data. I mean, when we prepared a report on excess mortality in Canada until the end of November of last year, it was a sort of, it was a motley group of us working on this. So it was me and, a public health master's student, and Janet Mcelhaney, a geriatrician, and Nora Laredo, who's a journalist who had been tracking all of the deaths in long-term care from the beginning of the epidemic and has this spreadsheet that I'm sure many of you have seen, but who was the only person who was actually tracking this throughout the epidemic and still is in every part of Canada. And when we were looking at workplace risks and we were looking at gender and race, there aren't really specific data for that in Canada. And so the best data that we had as of this last summer when we were assembling risk information was Nora has collected from the beginning every newspaper account that talked about someone who worked as who had a COVID-19 death that was potentially linked to a workplace. And she had tracked all of those, and those are the only data we have in Canada that cross-reference whether people were racialized, the type of job they had. Health Canada, PHAC, we track, people who work in healthcare and deaths associated with childcare and schools, I think, are the two categories that we track. And we don't track any of the others, but it's crazy, right? That a journalist who from the beginning has been tracking and keeping track of all these reports, that this is the best data we have in the country. And that's really concerning, right? As Ashley said, yes, some things have improved, but this is the 21st century and we have no ability to respond or forecast or anticipate what's going on if we don't have some of these data, which are not that challenging to collect, right? And every other major English-speaking country is collecting them and has been since the beginning and reporting on them. Anyway, there's a lot of frustration with that, but it shouldn't be that you've got a crew of like a journalist and it shouldn't be that you have this motley group of people piecing this information together, right?
As a journalist, I can say I agree, and it is a little bit difficult when you're you're looking to an expert for, an agency to say what data do you have, and they can say, well, we don't. Just an anecdote that I can share just on the lack of data that we have in general in Canada. So shortly before the pandemic began, I did a large piece looking at access barriers to medical abortions in Canada. So the abortion pill and how basically it's very difficult to access outside, big cities. And I think that it connects to COVID in the sense that I think a lot of the access issues where women are forced to go to hospitals in big cities probably did have a very big impact on the ability to access abortion during the pandemic. It's just one of those things that we don't yet know about. But during the course of my reporting, it basically was me calling every abortion clinic I could find and every hospital abortion provider I could find to sort of ask, do you provide access? How many pills do you give out? And, it is very, very, frustrating. We compare ourselves to the US a lot and how we do so much better in terms of health and health outcomes, but in terms of data collection, we do much worse. And I think that we're worse off for it, particularly when you think about some of these issues of impacting women and women's health. I was just going to sort of pivot a little bit and Iris, I'll get you to start off this portion. You know, we have a nice 15, 16 minutes left. So it might be good just to switch just a little bit to talk about, you know, we can't disconnect, you know, mental health from all of this. You know, we're talking primarily about physical health, but we know obviously mental health is greatly connected to that. And that study that you did, that looking at the disparity in physical activity between men and women, also found that during the pandemic, women reporting more sort of, as I think you said, it was generalized anxiety, or just sort of general anxiety levels among women were higher. And I thought you might be able to just kick off a brief discussion on what you're seeing in terms of that, you know, how that does connect to physical health, of course. And then I'll open that up to others to say, you know, we've seen a lot of reports of other things on the rise, you know, anxiety, depression, eating disorders, and the like. And again, these things are just sort of coming to the fore now. So Iris, if you could just start us off there, that would be great.
Sure, thanks. I mean, I think we've talked about this quite a bit in the sense that the pandemic really just brought forth what was already an issue. And, you know, there's been lots of articles written about how the pandemics really destroyed parents, parents with school-age children, young children. And when we talk about parents, as much as we try for equity in parenting, there's still a lot more burden placed upon women. And especially in the pandemic, we saw women taking on more of that childcare role and often having to leave jobs. And so this notion of women having heightened generalized anxiety isn't surprising, in the sense that they were already saying, help us, this is too much. I mean, this whole 2 working parent thing is great if you have support. And we took away all of that support. And so anxiety was going up, and with that chronic state of anxiety, of stress, it puts your body into that sympathetic response where you're just constantly elevated, your heart rate's elevated, your nervous system is on overdrive. And if you do that continuously, if that's how you feel every day, that's going to have a major toll on your physical health. You really can't separate the two. You know, the one thing about that study that was, you know, more positive was that we did see that the women who engaged in physical activity, who were able to somehow maintain that, especially if they did it outdoors, they really had better markers of mental health. They had lower generalized anxiety. And so, you know, it's like we took something that was already not doing great, like physical activity rates in Canada are pretty terrible. Physical activity rates in young mothers are even worse. And we took that and we basically said, let's put an extra 20 pounds on your shoulders and see what happens. And what happens is it goes to the wayside. And we have this opportunity to say, we can help you, we can make things better. But that needs to come through support for women and mothers.
Thank you for that. Nisha, I'm wondering if you have something that you can add there. You know, obviously you have a sort of a window seat to a lot of the things that are going on and impacts on kids. And so anyway, you might be able to reflect a little bit just on some of the, you know, some of those impacts we might be seeing. You know, we've heard about a disturbing rise in eating disorders and a whole host of other challenges. So yeah, I would like to hear your perspective just on some of those aspects.
Sure. So in Canada, in North America, really, there has been pretty solid evidence of higher proportions of mental health related emergency department visits, more among females compared to males and compared to females during the same period in the previous year. So, you know, something arguably related to the impact of the pandemic. And then specific to Ontario, there was a study that, and it's, you know, it's now quite a few months old, but reported that at that, you know, in this first wave and second wave, you know, females comprised at least 3/4 of the patient population with eating disorders during the pre and pandemic period, and had higher rates of inpatient admissions, emergency room consultation, and urgent referrals during the pandemic period compared to the same period in 2019. And you know, when the pandemic was cited as a trigger for their eating disorder, eating disorders were more likely to require urgent care and or hospitalization compared to those who didn't identify the pandemic as a trigger for their eating disorder, speaking to concerns around children and youth's ability to cope with this big disruption as opposed to a pre-pandemic disruptor. there has, beyond eating disorders, like I've talked earlier on about education and how that's been impacted. Well, and in our discussion around getting data in Ontario for Canada, there has been some efforts at this through StatsCan. So Statistics Canada had assessed the proportion of youth who were not in employment, education, or training, recognizing that the youth in these circumstances are at risk of long-term economic and social difficulties. And if the situation persists, which is always the concern around the pandemic, they can become more discouraged, disengaged, and socially excluded. And this one, this report was done in September, October 2020. So, in the second academic disrupted year, but still, it's been a year out. And I think, it would be really helpful to revisit the questionnaire and the circumstances, because at that time despite kids going back to school, they showed an overall attendance at high schools that had dropped by 2 to 3 percentage points for both sexes in that 15 to 19 period, as well as disruption in the school calendar. So so I think, recognizing that, again, school is such an important anchor for many students in terms of their psychosocial wellness and development, and how they navigate through life transitions in their peer groups. Really important for us to examine this further, because, to your earlier point, again, resiliency, it is really hard to talk about resiliency in the midst of a disruption. But what's really important for us as a society is to set up those structures that will help kids to recover the losses that they've had. And I'm talking about kids because I'm a pediatrician, but I'm looking to Tara and I'm like, we're not just talking about kids here. We're not just talking about we're talking also about those new mothers and and vulnerable people in society who need more structures to help withstand further disruptions and shocks, with further epidemics or pandemics. Although I really hope we don't have any more, but that would be part of the resiliency build.
Yeah, definitely. And and you're so right. So you mentioned Tara, so that's a good segue. Tara, if you have like a 1 or 2 minute addition to that, and also as you had just raised, there's issues also involving specifically women with disabilities. We've spoke briefly about the impact of the COVID on racialized women, but I think another issue that we haven't given enough attention to, women with disabilities, and how limited access and all kinds of other issues that have come up in COVID that we've sort of not really begun to address yet.
Well, in this, so it's not specific to women, but in some cases it is specific to women. So if you look at kids, for example, that have underlying health issues that made it less safe for them to go to school during COVID, a lot of parents, often mothers of medically fragile children that have different conditions that make them more vulnerable to COVID, have had an excruciating time through the epidemic, because because of uncertainty about the safety of schools or the safety of their children, they've, been more inclined to keep their kids home. This is extraordinarily difficult. You look at all the parents of kids, for example, with autism, who need a really, really strong support system for that. But you look at all kinds of people with disabilities who haven't been able to access healthcare that they need, haven't known or had confidence in the safety of the services that they need to access, if they even existed. And then the other part of it is that a lot of people with disability, a lot of adults who need care and support, and their families, including seniors in Canada, are economically impoverished as well. And so the people who in many ways are often most at risk we're most likely to have to use public transportation, not be able to avoid riskier settings. And this, enhanced people's isolation and lack of access to the intensive supports that people can need. And that's a really, really important lens because so many people with disabilities in this country are economically quite poor and have also hadn't had a lot of programs that were directed to help them during COVID either. It's been a really difficult situation.
Yeah, and that's something that, it's certainly not universal, but this is I think more common, a more common situation than a lot of people realize when you take the issue on a whole. And again, just so many issues that we just feel it's like we're ill-equipped to even address them. And that does actually bring us to one of the audience questions, which is from someone who's in her 70s, saying basically, how is the healthcare system going to be able to support me and care for me and others, given the fact that we have this aging population and our healthcare system it's been basically brought to the brink. She's referring specifically to Ontario, but we know across the country there's challenges. We only have a couple of minutes left, but so I don't know who would want to maybe start us off. Ashley, this might be one I can lob in your direction. This huge issue of basically now what? Now what do we do?
Yeah, I mean, it's the pandemic has laid bare all of the underlying health system problems that we have. It's been a really terrible, challenging time, and it's really highlighted issues that have existed pre-pandemic. I mean, we have this huge access to care deficit now, and I think my hope is that we learn from this. As terrible as a time as this has been, we've brought to, I think, the general public's consciousness a lot of issues that, unless you were directly affected by them, you probably didn't think a lot about. And so, it's clearly not an easy problem to solve. If it was, we would have solved it. But I think, I remain somewhat optimistic that, we have a lot of people who have become advocates over the past 2 years because of this pandemic. And I think, what we need to do is try to harness that, as much as possible. Like, we're seeing some transformation in the long-term care system. And, we need as much as possible to not forget about that. We've seen when it comes to COVID that we have this tremendous capacity to screen people, get testing to people. We have a very great capacity to get vaccines to people. We, recognize the importance of science communication and reaching out to people and outreach and, engaging with community partners. So, I mean, I think we've learned a lot, and similarly with the virtual care system, we've made progress. It's really just a matter of how do we sort of harness that political will to make sure that we actually transform our health system, because that's ultimately what it comes down to, and that's that's not the easy part. That's not easy, but I think the pieces are there. It's really a matter of how do we make that a reality, and I don't know the answer to that.
Iris, maybe I'll turn to you for the last word. We sort of have just a minute left, and maybe you can just give like a 30-second solution to all of the healthcare system problems, or just just some of the insights that you gleaned or learned, and things that maybe moving forward can help us address some of these gaps in women's health.
I mean, I certainly don't have the answer to all that. I do think the positive spin on it is, like Ashley said, that we've learned what's lacking. We've learned what's missing. We've learned what maybe we want to focus on. There's going to be a lot of challenges in making that happen. One thing for sure is I think we learned that mental health matters. And that's been, part of the conversation for a long time, but didn't really take front stage. And I'd say we've gotten that front stage. I mean, from what I've seen in advocacy, we get that it matters. We get that we want to focus on it. So I'll leave it there with 30 seconds on the plate.
Thank you so much for that. And Yeah, we are basically out of time, but, I know that this is a topic that everyone is interested in here on the panel, and just a flag that, pretty much anyone who is a female who has an online presence these days is dealing with a barrage of abuse and harassment, and especially when it comes to issues relating to COVID. So I just want to thank everyone for being voices and leaders, continuing to speak up even when, terrible abuse is coming your way. We need to urgently address some of the issues on social media and other platforms, so that women, particularly racialized women and other marginalized groups, can continue to participate, because otherwise that, I think we do risk, losing some really important voices there. And hopefully next time we can maybe dedicate an hour just to that topic, because I know everyone here has something to say. But with that, I just want to thank everyone for being here, for donating their time to this amazing discussion that we've had on women's health. There's many more discussions to come on what we do next, but I know that with all of you guys helping to lead the way, we're in good hands. So thank you everyone for participating, and thanks to all of those who are viewing, and maybe next time we can all meet safely in person.